was hoping to be BCI Thursdays. This was an initiative set up by the Postdoc and Student Committee a couple of years back with an effort to bring together industry and academia and have presentations that delve into kind of the cutting edge of BCI and hear from both industry and academia. We're thrilled to have our speakers today, Dr. Sergey Stavisky and Dr. Ben Rapoport, representing both academia and industry. Couple things, I guess. One thing I'll do is I'll paste the Discord into the chat. We have a Discord, and we were hoping maybe to continue discussion after the talks today on there. This is open to BCI Society members. And I guess anyone who catches this talk once it's been recorded after the fact, maybe they can find the link on the website. But I'll start off by introducing Sergey, and Valeria will introduce Ben. These two speakers today probably need no introduction, but to this audience. But Sergey is currently at UC Davis. He runs the neuroprosthetics lab there, along with Dr. David Brandeman. He's an assistant professor in the Department of Neurological Surgery, and he's currently works as a neural engineer and neuroscientist. Previously, he trained at Stanford, where he got his PhD and postdoc under Dr. Krishna Shenoy and Dr. Jamie Henderson. He's dedicated his career to developing motor BCIs, pushing the limits of motor BCI performance. And his lab currently focuses more on speech BCIs. As a former postdoc and student committee member himself, we're thrilled that he's taken the time today. I know you all are both incredibly busy, so we appreciate your time and your patience with the glitches. Valeria, you want to introduce Ben, and then we'll get going. And then one last thing, we'll just whoever is a guest here listening, just post questions, and we'll get to as many as we can after the talks. We'll plan to end at 3 p.m. Eastern time, and then, like I said, any lingering discussion that goes on afterwards, we can maybe do that on Discord. Tan has done a really good job of setting up the Discord, and we can continue conversation and questions there.
Yeah, sure. So Dr. Rapoport is a neurosurgeon at Mount Sinai and is the co-founder and chief science officer of Precision Neuroscience. He completed his MD at Harvard and his PhD in electrical engineering at MIT. And actually, he was also one of the co-founder of Neuralink. And in 2021, he founded Precision Medicine. And actually, today I am at the MBC conference in Orlando, and there was an amazing talk by Precision Neuroscience about the 7-layer cortical interface and also about like the impact in patients and the future of BCI with the main leading company in the BCI revolution, such as like BlackRock, Onward, and of course Precision. So we are really happy to have you both here, and thanks a lot for your time, actually.
Thanks for having us.
Yeah, thank you.
Would either of you, who would like to go first? We kind of didn't plan that out ahead of time.
I'm fine with either order. Ben, do you have any constraints? Do you want to go first or second?
No, I don't have a constraint, Sergey. It's a pleasure being here with you. Why don't you go ahead and I'll follow, and then we can take it into the Q&A.
Awesome. Thank you both.
Okay, great. So I'll go first. Let me try to share my screen. You need to enable screen sharing for me. And then one of my first videos will have sound. Please, somebody speak up if the sound is not coming through. That's always a sticking point. All right, let's try that again. Nope, still disabled.
So just one thing, like maybe there are still person in the waiting room. We can check. Sandrine?
Yeah.
No.
Let him in.
So sorry, I'm letting people go, and I'm trying to like share. Can you see if you can share now?
Yeah, great. Okay. Yeah, now it's letting me share sound, optimize for video. Okay, can people see my slide?
Yes.
Yes.
Okay, great. All right, so thank you for inviting me. This is really fun to be here. And indeed, as was said, just 3 years ago, I was a postdoc that was on the postdoc and student committee helping set up this kind of seminar. So it's really fun now kind of being on the other side. By the way, sorry, are you seeing my main slides or the like presenter mode?
Yeah, we can see the whole slide.
Okay. So
Just
like,
the slide, not the presenter mode.
oh, okay, great. Yeah, sorry. For some reason, the green bars in the round. Great. So I'm going to talk today about a couple, one big project from our lab and a little sneak peek of a second project. It's certainly not everything we're doing, but we got started about 3 years ago. David Brandman and I are co-directing our lab, and we're really proud and excited to share some of our initial results. I want to start by introducing the problem. Right? So we are developing brain-computer interfaces for restoring communication. So I'm going to play this video. This is going to show a gentleman that we're going to refer to as T15. That's his code name in the clinical trial. And he is a man in his 40s living with ALS. It's a neurodegenerative disease. And you're going to hear him trying to talk. And I think what you'll quickly notice is that he is severely dysarthric, and it is very difficult, if not almost impossible, to understand what he's saying. Okay, so if you're like me, you probably couldn't understand what he was saying. Obviously, this is a rather difficult situation to be in. We currently have no way to stop ALS. We can't cure it. A lot of people are working on that, and I hope they succeed. But in the meantime, how can we help this person and people like him communicate more easily? Well, we are trying to do this with a brain-computer interface. So as you can now see, there are these percutaneous connectors, these little boxes of electronics made by BlackRock Neurotech with HMIs coming out. And so he is part of a clinical trial. This is a BrainGate 2 clinical trial. It's been running for well over a decade now and has recently moved on from, or expanded from cursor control to also working on speech restoration. So let me now literally flip the camera around, and you're going to see the same 10, 15 seconds of time from the other view. And what you're going to see is that as he's trying to speak, this BCI is actually reading out neural activity from 256 electrodes, and I'll go into more details in a second. And you're going to see the decoded words appearing at the bottom of the screen. So he's trying to say or read what's on top, and you're going to see the BCI output that in real time.
Maybe after we're not in school anymore. And they're very dedicated to that.
Okay, so how does this work? Well, it starts, of course, with a sensor. So this planning and procedure was led by David Brandman, my lab co-director. He's a functional neurosurgeon. And so what he did is implant 4 64 electrode Utah arrays, which you can see in this video, into the ventral precentral gyrus, so speech motor cortex and middle precentral gyrus, area 55B. So in the video, you could see the arrays going in. So that gets us access to single neuron resolution kind of spiking activity. You can see the arrays here superimposed on the brain areas that they're in. So we have what we think is 2 arrays in ventral premotor cortex, area 6V, 1 array in the primary motor cortex, which is somewhat unusual because it's typically in humans buried in the gyrus, but here it's kind of at the surface, and also 1 array in this area 55B, middle precentral gyrus. From there, this is kind of the classic signal processing and decoding pipeline, and this is work led by Nick Card, a postdoc in our group. So we take in the 256 electrodes worth of data as the person is trying to speak. We pass that through a recurrent neural network that at every time step, so every 80 milliseconds, it calculates the probability of all 39 English phonemes or silence. And so we get a time series of phoneme probabilities. Phonemes, for those who don't study speech, you can think of it as the building block of speaking, of words, so kind of like a syllable. And then those phoneme probabilities are stitched together into words by a language model. And then at the end of each sentence, we also run it through a second larger language model, a GPT, that basically, think of it as an autocorrect, kind of corrects mistakes that would not be grammatically or semantically reasonable. So from that, we have our highest probability word sequence. And then when the user, the participant, indicates that they're done, either by trying to click his hand or squeeze his hand to click, or using an eye tracker, or just waiting a few seconds, that sentence is read out loud, as you heard in the video earlier. And in fact, the voice that you heard was basically a deep fake of his voice. So it's what we call an own voice text-to-speech, which was trained using some home video and audio from before his ALS. So to the best of our ability, we make the computer read these sentences or words out loud in his own voice. So let me illustrate kind of what this looks like with somewhat raw data. So here is the microphone recording. So as you could hear, he can vocalize, it's just not intelligible. So in this case, he's trying to say everything isn't always somebody else's fault. We can, in this data, see clearly when he was trying to say each word. Now I'm showing you the spike band power on all 256 electrodes arranged by array. And even, you don't need any fancy ML to see that when he's trying to speak, and in fact, shortly before every word, there's a large increase in firing rates, right? So a lot of activity corresponding to speech attempt, and that's what we're trying to decode. From there, now I'm showing at every moment in time the most likely phoneme. So it's typically silence in between words, and then during each word, there is a bunch of phonemes coming out. You can almost read the sentence just from the phoneme sequence. And then once that goes through the language models, you get a actual sentence out, which in this case is correct. We were very happy with the performance of this system. So starting on the very first day of recording, which was a few weeks after the implant, we initially went with a 50-word vocabulary, kind of replicating some prior work in the field. And we found that our word error rate, which is exactly what it sounds like, 0% means you get everything correct, that's good. 100% means everything is wrong, that's bad. So we want to be closer to 0. On that first session, our 50-word error rate was, 50-word dictionary, I should say, there were many more words actually said, was close to 0. On our second day, we replicated that with actually 0-word error rate, and then expanded the vocabulary to 125,000 words. So this is a very similar setup to the recent paper from the Stanford group, the Willett, Kunz, Fanadol Nature paper. So same vocab, 125,000 words, basically every word in the English dictionary except some proper nouns. And our word error rate was just under 10%, which was really exciting because if we compare that to some recent speech BCI work in the field, the Chang Lab paper and the Henderson group paper, both of which had word error rates of around 25% with a lot more training data, right? So we were already doing better than that and kind of at a point where this system could be used for open communication. So just saying whatever you want to say. That was really exciting. Of course, more data is better. So we kept doing this for many, many weeks. And as you can see in the plot, as we added more data, and there was also a bunch of algorithmic innovations and fine-tuning and kind of a lot of ML stuff going on under the hood, basically word error rates trended down to the point where we were averaging about 97% accurate. So 2.5% word error rate on average over the last 5 days. Some of the best days had word error rates as low as 1%. And we've continued to actually record. So even out to 240 days, and in fact, this is a few months old now, so we're currently at about a year out, the word error rates remain very low. So I bring this up because obviously we want a speech and neuroprosthesis to work for a long time. I know there is quite a bit of discussion about the longevity of implanted BCIs in general, and microelectrode arrays in particular. And so we're really thrilled to see that the system just keeps on working at least 1 year out so far. Now, getting into some of the technical details, which people in this audience I think will appreciate, there's always this question of, well, what specific brain area is contributing, right? If we're going to put electrode arrays in there, where are we going to get the most information about speech? So as I said before, we've got these 4 arrays, and we can quantify if we were to offline decode from just one of the arrays and look at the raw phoneme error rate, so this is without a language model, which ones are doing the best. And what we found is that the ventral area 6V array and the 55B array are really the 2 best ones. Primary motor cortex area 4 is pretty good. And then this more dorsal 6V1 is not so good. It still has information. It's definitely below chance, but it's not contributing a ton. So kind of 2.5 arrays are doing most of the work. Okay, so obviously the goal of a speech neuroprosthesis is not to do a copy task where you read sentences from a screen, it's to communicate. And so having established that we have quite good accuracy, even on that first, or rather second session, we wanted our participant to be able to communicate whatever he wanted. And so this video is going to show the very first time that we told him, just say whatever you want.
Hello, is this on?
You can see the words update with the language model.
I'm looking for cheetah.
And you can see it go on. So basically, he's using the system to talk to his young daughter, which is, of course, very, very sweet. You can imagine how impactful this is on him and his family, given that he hasn't really been able to speak to them in a couple of years at this point. Okay, so a couple features of the BCI are particularly helpful for making it kind of a daily use communication system. And the first is that these decoders are quite stable. So here we're plotting an offline analysis. If we train a decoder from 5 days worth of data and then hold it fixed and just evaluate it moving forward multiple days, what we see is that up through about 20 days, the word error rate stays very low. And after that, things get worse. There's some signal non-stationarity. Okay. But if we fine-tune the decoder by basically using every sentence, if it was correct, and he can self-report it with an eye tracker or with a mouse, we can use that to immediately update the decoder. So basically, within a few seconds of it completing a sentence, if that sentence was believed to be correct, we're using that to fine-tune the machine learning models. And so using the system, it would appear that it can basically stay accurate indefinitely. So at least up through 70 days in this analysis, this fine-tuning keeps the word error rate very, very low, below 5%. And the second nice feature is, does it inadvertently trigger when you don't want it, or does it only output phonemes and words when the user is trying to speak? So we could analyze that by looking at this copy task data, where we have 3 epochs. There's an instructed delay, where he's preparing to speak. There's the go epoch, when he's asked to actually try to speak. And then there's the post-trial epoch, which is important because that's when the text-to-speech is speaking the sentence out loud. And so if there was an interference effect with auditory perception, we might see a false triggering of the speech decoder then. But if we're looking at what percent of trial epochs was speech detected during the delay, it's below 1%, which is good. During the go epoch, 100%. It always detects when he's trying to speak. And when he's listening to speech, it's again well below or below 1%. So very, very few, if any, false positives. Basically, this system will only activate when he's trying to speak. And so if you put that together, we now have a somewhat fancier looking interface, which we call conversation mode, which basically just allows him to use the system to talk through the computer whenever he'd like. So I'm going to play a video. This is kind of like that earlier one when he was talking with his daughter. And again, he's going to be speaking to his daughter. But you can see an improved interface and also a much better text-to-speech. So it actually sounds a lot more like him.
Hello, my sweet child.
Because the language model suggests corrections if there's a word wrong.
Would you like to talk with me? You are a good kid, and I am proud of you.
So given all of this work that went into conversation mode, as you can imagine, he might want to use it a lot. And that's what we found. So here I'm plotting the cumulative use time in hours over the first 300 or so days. You can see he's using it quite a bit. On the right, the pie chart is showing those self-reports of what the output was. So the majority of the time, the sentence is 100% correct. About a third of the time, it's mostly correct. Usually there's one or two words wrong. And then about 11% of the time, it's incorrect. So there he would re-say the sentence. At one point, we finally got kind of regulatory approval to actually allow his care partner, his spouse or assistant, to don and doff the little pedestal connectors without our research team there. And we put in a lot of work to automate the software. So basically it was double click to turn it on. And as soon as that happened, you can see this rapid explosion in use. So where we are now is this cart of electronics lives at his house, as it always has. But instead of the research team having to go there, which we still do for research sessions, but when we're not there, his family can connect the system to him, which they usually do in the morning. They can press a button, the software boots up, and he can start using it. And you can see that he is now using this a lot. He uses it to talk to his friends and family, to talk to us, which is great for enabling the research. He still works, so he Zooms with his colleagues, he writes emails, he writes documents, and to date, our record is over 14 hours of use in one day. So it really is a daily communication system that is immensely useful. And in observing how he uses it, we continue to refine and update it. So basically, we're learning a lot about how someone would actually use a speech BCI at home, because that's what he's now able to do. So with that, I just want to transition briefly to one other point. Speech is, of course, a very fast and naturalistic way to get information out, to communicate. But to use a computer, you also really want to have point and click control. Basically, you want to use a computer mouse. And so in parallel to this, there's been a project led by a PhD student in our group, Tyler Singer-Clark, to see whether we could decode point and click control with attempted arm and hand movements from this area. Now, cursor control has been done for decades, but to our knowledge, it's never been done from speech motor cortex. And that's important because for the time being, it's really hard to put arrays across all of motor cortex. It can be done, but we wanted to ask, could you get away with just putting all of your electrodes in speech motor cortex, which is important for maximizing speech decoding performance, which is a harder problem, but do you still see enough hand tuning in that area, even though it's not the strongest feature, to control a computer cursor? And so here you see him doing this classic grid task, which gets you a bit rate. And the answer is yes. So he has good point and click control. It's about 2 bits per second. Definitely not going to set any records, but that's enough to accurately use a general purpose computer. And so that's what I'm going to show you in this last video. I'm now going to kind of zoom in. This is a screen capture, so you can see more clearly what's going on. What you see is that at the top screen, that's our research BCI system, which in this case is not doing speech decoding, it's doing cursor decoding. But at the bottom, this is his personal computer. So our system has a small widget that's running on his MacBook, but otherwise it basically acts as a Bluetooth mouse and keyboard. And so you're going to see him just trying to move his hand to control that computer cursor. He's opening Netflix, he's going into his account. He doesn't want to watch whatever trash that is. So he's going to actually move over to use the scroll bar, which is a pretty damn small target. So I was impressed that this worked. He was able to scroll down and then go and select the show he wants to watch. So, pretty cool, very useful. And so to summarize where we are now, we have what I consider a very good brain-to-text speech BCI. It enables fast and accurate communication, as you saw. And he's actually now able to use it every day at home for his daily needs. Awesome. Important caveat, this is an N of 1 study so far. It's a person with ALS, severe dysarthria. Based on work from other groups with subcortical stroke, we think this would work in other etiologies like stroke, but remains to be seen. And we think it'll replicate, but again, remains to be seen. And then also this kind of secondary, but also important point that even with all of our arrays in the ventral and middle precentral gyrus, which is optimized for speech decoding, we can also support computer mouse control. And so you put these two things together, and it basically means that you can use the computer about as well, let me back that up, close to as well as an able-bodied person. You can talk, words come out, you can write emails, you can write text messages, and you can use a computer mouse, allowing you to basically use any application. And so, together, I think we have a pretty practical system that is pointing to something very useful. And I think this is actually a very nice transition to Ben's talk, because maybe the key thing that's missing is that, we've got these pedestal connectors. That's not an ideal form factor, of course. So if only some companies were around to make a fully implanted system that could run this type of algorithm, I think that would be really exciting. So I'm going to stop here and take questions. But sorry, I'm just going to leave off on 2 more slides. This is a quote from him kind of explaining the impact of this work. So I'll let it play. You can see he can write very long paragraphs with the system.
One of the things that people with my disease suffer from is isolation and depression, because they do not feel like they matter anymore, and something like this technology will help bring people back into life and into society.
Yeah. So I think that really kind of summarizes our mission statement and what we as a field need to do. So perhaps the most important slide is the acknowledgements. This is a huge team effort, especially as a new lab. Everyone has really pitched in to build the software from the ground up, run the experiments, get the data, iterate. It's been really an all hands on deck effort. So huge kudos to the team here, to David, my lab co-director, our various sources of funding, our collaborators within BrainGate, and our participants, in this case, especially T15, who's the gentleman that you saw in all these videos. Nothing like this happens without very dedicated and brave participants who do this research. So I'm going to stop and answer any questions.
That was awesome. Thank you.
Thanks.
Hey, can I ask a question?
Totally.
First of all, that was awesome. It's such a pleasure to give side-by-side talks. I'm curious, ALS progresses over over a couple of years, and that's one of the reasons that patients with ALS are often on the more kind of avant-garde side of of the patient populations we think about as potentially being receptive to innovative technologies, because they know that their disease is going to progress relatively rapidly and they have a limited time left. What have you seen in terms of the efficacy of the system and the and the decay of decoding performance and other performance parameters as his disease has progressed in the year and a half that you've been working with him?
Yeah, it's a great question. So we're 1 year out and we have not seen a change in performance. So that's good.
And has he had clinical progression of his ALS, or has he been in relatively good shape?
It has progressed a little bit. I don't want to get too into the details of his clinical situation. But yeah, I mean, there is some progression. We have not noticed it through our decoder yet. As you said, unfortunately, we will probably find out. We certainly intend to keep working with him for as long as he wants the system, and I suspect he will continue to want it. So yeah, that's a big question, is will it continue to work later? We just have to wait and find out. But so far, so good. Chetan?
Hey, just that was fantastic. Great job, Sergey. Since somebody else is speaking up, I get to ask fun questions. I mean, the work is remarkable. Clearly, the brain to text system is already quite useful for him, kind of in his everyday life. I'm curious. Do you think that brain to text is kind of the right modality, or like what modalities do you think brain to text or applications is brain to text best for, versus something like brain to speech? And like which is better for conversations, which is better for other applications, etc.
Yeah, so right, so kind of the distinction there is brain to text is you decode essentially text, which you can then vocalize like at a time of the user's choosing. Contrast that with what we're calling brain to voice, which we're also working on, which is instantaneous sound synthesis. And I haven't talked about that, but that is another major arm of our lab. Brain to voice is harder. So the language model buys you a lot. It denoises things a lot. Our brain to voice, which we're hoping to have a preprint out soon, we think it's excellent as far as the field goes, but it is not yet consistently intelligible. So for just like talking to people, it is, it's not good enough yet. And I've yet to see anything that is good enough. Obviously, that would be better. If you're having a conversation in a room, one of the annoying things about brain to text is there's this, it's just a different dynamic of, it's like, think about all the issues with Zoom with like people unmuting themselves, but even worse. And actually, we've done a little bit of things for that. Like there's like a horn that he can use just to get people's attention. He can repeat the previous sentence. So there's a little like, we've learned ways to mitigate that, but it's definitely not, brain to text is not ideal for speaking in a room. I think for kind of, digital communication, Slack, email, message, whatever, like professional stuff, or, just writing to your family, it's great. I mean, we spend a lot of our time writing text messages anyway. So I think it's already hugely enabling for that, but it is not the ideal communication modality for just talking like on the phone. So there's definitely work to be done there.
Yeah, thank you. I mean, it's really encouraging to see that. I mean, with performance like this, brain to text is maybe close to a solved problem, but it's helpful to know kind of what the open problems in the space really are. Thanks.
Yeah. I mean, yeah, it's kind of a solved problem. There's room for improving the algorithms, especially like if you don't have as good SNR, there is room for improving it. And it's not like we're not continuing to improve it, but I'd say it's this is an existence proof of good enough brain to text performance.
Well, maybe I can pick up there since it's like such a natural transition, and happy to continue a joint Q&A at the end. I'll leave time for joint Q&A for both of us. And are you seeing my screen okay? Is there anything blocking the window?
No, looks great.
Yes.
So great. Okay, thanks. Really, it's such a pleasure to be here. Thanks for inviting me, and thanks for pairing up the two of us. My disclosures, I'm, as was mentioned, co-founder, chief science officer of Precision Neuroscience, and my academic affiliation is at Mount Sinai Medical System in New York City, where I'm assistant professor of neurosurgery. Just to start out with my thank yous, there are lots of them, including to the now, as of yesterday, 17 patients in our early stage clinical trials. Thanks to all of you and to the students, residents, and fellows who've been involved with the work. And what I'll say is that, for me personally, this has been more than 2 decades of work in the field of brain-computer interfaces. And some of the early ideas behind what precision and our work has become have been work in progress for all of that time. And one of the things that means to me is that for those of you who are in the audience who are students, residents, fellows, I think there are a lot of good ideas that we won't know about until 20 years from now. So thanks for listening, and thanks for the work that you're going to do and are already doing. Thanks to the BCI Society for having us here today, and of course to the amazing team at Precision Neuroscience that's responsible for some of the work that I'll be presenting, and to our clinical collaborators at Mount Sinai, WVU in West Virginia, and Penn Medicine. So I don't think that speech to text or speech to voice or speech to motor control or speech to digital interface is a solved problem. But I love the comment that that we have an existence proof, several existence proofs for good enough performance, which is a hugely impactful thing. Having an existence proof is really important because I think, and the quality of the existence proofs that we now have, and we've seen in the last talk an amazingly good one. It inspires us to say, do we feel that this is ready to develop into a real product that can be scaled, manufactured, brought through a regulatory process, and actually used in patients and beyond, and to become part of the standard of care, and maybe even part of modern society as we know it or will come to know it. I think about brain-computer interfaces as communication systems between the brain and the digital world, and as we all know, communication systems really benefit from not just high bandwidth, but scalable bandwidth in a way that can be expanded beyond, beyond our current perceived needs and limitations. And that concept has been one of the inspirational philosophies behind the system we've been developing at Precision. And so what I'll try to focus on in the next 15 or 20 minutes is some aspects of how we've begun to productize brain-computer interface technology, scale it, and move towards validation, verification, clinical work, productization, and developing, standards of care around what we hope, I think all of us hope will become, a routine part of medicine. One thing that I would like to just begin with here is, a lot of the work that I think we see in the society focuses on different types of electrode interfaces, all the way from, scalp EEG to conventional electrocorticography, as is shown in the AdTech electrodes on the right. And then, of course, Utah-type electrodes or Utah electrodes themselves, like what Sergey was showing in the prior presentation. And for a variety of reasons, at Precision, we started, when we founded the company, working on something quite a bit different, and that is microelectrocorticography. So very small electrodes, 50 micron diameter surface electrodes with a similar or identical spacing to those used in the Utah electrode array, but with the ability to cover larger areas of cortical surface. So just in comparing the one of the Precision array modules to one of the Utah array modules, as is shown here. So we have 1,024 electrodes. The larger ones you see here, I won't focus on it, but just as an FYI, are optimized for stimulation. But mostly what I'll talk about here is recording. And so the little recording electrodes, of which there are 977 in this electrode array, they're all 50 microns in diameter. They're spaced at 400 microns. And so the array covers about 10 times the surface area, the cortical surface area of a Utah electrode array. So what I'm getting at is we've tried to solve for some of the real estate problems that Sergey was alluding to. Do we want to focus on speech? Do we want to focus on motor? Are we sensitive to small differences in where hand or speech is in a particular patient? How do we map that out? All these practical problems that go beyond the existence proof to how do we make this scale. And at the time, even 4 or 5 years ago, there was a real dogma in the BCI field around the use of intracortical electrodes as being the only valid or likely to succeed source of neural information for a BCI. And of course, the field has come a distance in the last 5 years towards understanding that a lot of information, decodable information, is available at the cortical surface. But of course, 5 years ago, that wasn't as clear to everyone. And so some of what I'll talk about here is how we validated that for ourselves to confirm that what we were doing was going to be the valid basis for a scalable BCI. Just for those of you who haven't experienced these surface microelectrodes, they are thin film based, so they're embedded. They're platinum electrodes embedded in a thin polyimide film that's 22 microns thick, and so it's translucent. And what you see here on the top is the electrodes in place on the brain surface, and then after removal, so you can see there's absolutely no damage to the peel surface. And that has a number of advantages that we can talk about, another time. Another thing that we've innovated on at Precision, just in terms of wanting to be able to scale the system, is surgical delivery. So the idea of having to have a conventional craniotomy for placement of the electrodes in some ways limits the ability to scale to many patients. There's definitely a desire to have a more minimally invasive access options. And so we've developed a technique called we call it the cranial microslit insertion technique, which is sort of artistically rendered here, which allows us to make just a very targeted small incision in the scalp and in the skull, and to deliver the electrodes onto the cortical surface without a burr hole. I'll skip the surgical deployment video. Maybe we'll show it in the Q&A if there's interest, or another time. And I just want to give you, I think a lot of us have intuition for what spike rasters look like and what the raw data looks like from a Utah type electrode array, but I want to give you some intuition for what the data look like from microelectrocorticography. So here I've slowed it down about 20x. But what you're seeing is, does the video come through all right? Each of these colored dots is the real-time voltage underneath one of the 50 micron recording electrodes. So hot colors like reds and oranges are the high voltages from the analog to digital converter, and the cool colors, the blues and so on, are relatively low voltages from the ADC. And I'll play it again. What you can see is that there's traveling waves that move across the cortical surface. This happens much quicker than even our eyes can detect it. That this happens at a scale that's sub-millimeter. I think before we started looking at this, people didn't really appreciate that there was spatially resolved electrical activity at these scales. They thought all the action was really at the level of the individual spikes, but there's a lot of very spatially resolved action that's happening on the cortical surface at these fine scales, and so it's only when we start to look that we realize. And to give you a little bit of intuition for why that's the case, and we could talk more about it, because what really matters is just the empirical fact. But to give you some understanding of why, all areas of the cortex are arranged in in columns or microcolumns or whatever people want to call it. And when, for example, motor intent is translated into motor action, what happens is that the coordinated firing of hundreds or thousands of pyramidal cells in the motor cortex results in a signal being generated on the spinal interneuron, and then finally the end plate potentials on a skeletal muscle, right? And so it's those hundreds or thousands of pyramidal cells firing happen in a small fraction of a square millimeter in a neighborhood on the motor cortex, and that is measurable at the scale that we're reporting from here. And that applies whether it's the conscious movement of a limb or finger, or the articulatory apparatus that gives rise to speech. So those are the scales that matter. Of course, you can get it from the action potentials, but you can also get it from the microecog. And there are various ways. One of them is shown here of kind of analyzing these traveling waves. You can look at when you feed this into a convolutional neural network, you can do it at the level of individual electrodes, or at the level of the traveling wavefront, or any of a variety of different features. And I think that's a subject for another time. But this is what I'm trying to convey here is that this is very, very rich information. I think much richer than the community initially appreciated, and the spatial resolution is much higher, even at the cortical surface, than we even thought about a couple of years ago. I won't dwell on it, but this is just to show that another feature of these cortical surface electrode arrays is the ability to stim and record kind of almost at the same time, and to watch the effects of a cortical stimulation as they propagate across the cortical surface. And of course, we showed in preclinical work that I won't dwell on here, that we can decode motor activity in real time. This is just showing a pig walking on a treadmill with in this case, I'm showing 1,000 of 2,000 electrodes on her bilateral motor cortices, and we have the ability to decode spontaneous untrained motor function, head and limbs in real time. So this is really what gave us the work that gave us confidence to move forward into human clinical pilots. And I want to just show just a few examples of what we've started to learn and to tell you about how we've started to take this work from the preclinical arena into human patients. You know, what Sergey was alluding to, you know, the difference between you know, an N of 1 type study that proves, you know, with incredible beauty the you know, the existence and the possibilities of what these systems might do, and the difference between that and a product. And there's lots of unsolved problems along the way, and some of them we want to tackle in a kind of incremental fashion, making as few changes to things we know work as possible, and some of them we kind of need to you know, push hard against. And one of the ones that we try not to innovate on too much is the form factor of you know, of a neural implant. And so I think all of us here are familiar with you know, DBS and RNS type systems, and the form factors that those have been built out into over time work pretty well. They involve some kind of a head stage, some kind of a tunnel lead, often in the chest, sometimes elsewhere, like in the head. And so the precision system is configured similarly. We have an electrode that's a cortical surface electrode, like what I showed you earlier. We have a subgaleal, meaning between the scalp and the skull, head stage that contains the you know, the signal processing electronics, amplifiers, analog digital converters, and so forth. And then the power and data telemetry lives in a chest wall unit. So there's a rechargeable battery, there's an antenna for battery recharge, as well as another antenna for wireless data telemetry. And the difference between, you know, the DBS and RNS type systems that are out in the world today and the BCI type systems that we are all interested in, I think is sort of obvious to everyone in this room, but maybe not obvious to industry. And so in the BCI world, you know, decoding is therapy, which means that, you know, we're focused on recording and analyzing recorded information in real time, which is kind of the flip side of what certainly what DBS does, which is essentially just an open loop feed forward stim only system, and you know, different in character from what RNS does. You know, RNS uses to you know, record signals to determine stimulation, but none of these kind of current generation systems is optimized for the total information rate and the nature of decoding as therapy, because you know, historically for the last 20+ years, the thinking about neuromodulation systems has been that stimulation equals therapy. So it's for industry focus, you have to flip a switch to you know, to kind of bring that home. And one of the things that we think a lot about when we're trying to productize these systems is I'm getting a connection unstable warning. Is my presentation still coming through okay?
Yes, we're losing your audio a little bit, but you're doing okay.
Okay, let me know if it becomes audible. I can always switch Wi-Fi or something. Or maybe I'll turn my video off for a minute if it's not. But let me know if it becomes a problem, and I can always turn the video off or do something else. So we're really trying to you know, maximize information content, maximize cortical surface area covered, you know, and maximize access and functionality for patients, you know, while minimizing the time of the implant procedure, the collateral damage to the surrounding brain, and risks and morbidity for patients. So this is what again, different look at what the precision system looks like, from the electrode array to the head implant to the tunnel lead to the chest wall implant. And these are the components of the system. On the left is the electrode array connected to a hermetically sealed package that contains the signal processing electronics. In the middle, you have the chest wall implant. And on the right, you have the external receiver, which is what receives the transmitted data across the wireless link and allows us to connect via USB-C to basically any device. I want to emphasize that, you know, one of the kind of unsolved problems, which I think we've now solved, is, you know, how do we make these electrodes in a way that that scales and can be you know, safe and approved for human use. You know, medical devices, we take for granted, I think, a lot of the research grade tools that we use in the laboratory, but there's nothing that microfabricated on as fine a scale as what we need that's available in clinical medicine today. The electrodes that are used for brain mapping and diagnosis and so on are much coarser resolution than anything that provides the kind of rich information content that Sergey was talking about, and that we know to be necessary. And the manufacturing processes involved in making those kinds of electrodes are fundamentally different from what goes into making the standard of care electrodes today. So, one of the things that we have needed to do at Precision, we've now acquired and brought up to human implant grade a microfabrication manufacturing facility just outside of Dallas, MEMS facility. So this is microchip technology being used to make implantable electrodes, and that is a tremendous lift. It requires a lot of engineering expertise that's not traditionally available in medtech, and the approval process through the FDA and so on that we're currently going through is obviously rigorous. But from an investigational standpoint, we've now we've been manufacturing these electrodes at scale with very, very high quality for basically a significant period of time now, and we've implanted on a temporary basis more than a dozen of these electrodes in human patients with really good results. And so I wanted to maybe I'll spend the last few minutes showing some of what we learned in our early clinical work in patients, and to explain how we've gone about making the transition from R&D systems to clinical trials, and what comes next. And we have felt that in order to make sure that we're on the right track, and that the technology we're developing is really going to go in a stepwise fashion from R&D scale, really translating what we know from academic science into clinical medicine. We want to make sure that we don't make any missteps, basically. And so it's a big lift to bring a technology, especially complex technology, through the regulatory process, through clinical trials. And so we've tried to break it down into bite-sized chunks. And the first of those bite-sized steps really has been to achieve FDA clearance for these high-resolution electrodes. That itself will be a major contribution to the movement of BCI from academia into clinical medicine. And so we're anticipating within the next couple of months, hopefully, an FDA clearance for these electrode arrays. That's been a tremendous amount of work, and that will allow, in a more scalable fashion, us to bring some of this early electrophysiology work into the operating room and into the critical care setting, and eventually to do the sort of work that what Sergey was showing in an N-of-1 fashion to dozens and hundreds of patients, instead of through I can't imagine the hoops, and I can easily imagine the hoops and red tape that you had to go through to get that one patient, the system that is working for him at home. But in order to make that scale, we have to bring the whole system through regulatory approval processes. And so this has been the step one for us. And so we have an investigational version of the system, percutaneous, not dissimilar from what Sergey was showing, but that will be FDA cleared. So it won't just be on a one laboratory at a time scale. It will be basically available for commercial use. And that is for us the step before what's shown on the right here in box number 3, which is a totally implantable wireless version of the system, which is also in development, and we hope that will be available for use a few years beyond. But that's going to require a higher bar of clinical trialing than what is required to get the percutaneous electrodes cleared. So I just want to show you. You've seen from Sergey the kinds of things that are possible, with the implant. And I want to show you some of the things that we've learned along the way as we've started to use these electrodes in a temporary fashion in the operating room. And actually, we found some really, I think, interesting and in some ways surprising things, which is that when you bring out a new tool, maybe it's not so surprising that when you make a new tool available in a scalable fashion, you put it in somebody else's hands, you find maybe some things that that we didn't totally anticipate. So here's how am I doing on time? Maybe a couple minutes more, and then I'll stop and we'll go to questions. So here's just, many of you know that electrocorticography is used for mapping location of seizures, and also one of the critical things that we use these electrodes for, even when they're at a more coarse-grained scale, is to find where is a primary motor cortex, where is primary sensory cortex, where are the functional areas that we care about in the brain. Because when you show a nice 3D rendering with color maps and all the Brodmann areas nicely labeled, it makes it seem so simple, right? But the brain doesn't come with labels, and we know that small changes in positioning of the electrodes, as Sergey was showing, give us drastically different results in terms of decodability and performance. And so, one of the unsolved problems, is like, where do we put these electrodes when the brain is open in front of you, and and you're looking at something like this? How do you know where to put the electrodes so that when you close the head, you have do you have 10% word error rate or 50% word error rate, right? And that millimeters matter. So how do we do this? So one of the ways is to do cortical mapping with the patient awake, and there's lots of ways of doing this. One of them is called the technique called somatosensory evoked potentials, and that's in where even with the patient asleep, you can sense where sensory and motor cortex lie. And I'm showing you how this works in sort of quasi real time. And what we do is that even with the patient asleep, you can stimulate their hand. It's kind of like like they're receiving a tactile stimulation, or you can stimulate the nerves of the upper extremity, like median or ulnar nerves, or their digital branches in the fingers. And when that happens, there is a depolarization at the level of the primary sensory cortex of the hand, and there's a corresponding reversal of polarity of that impulse that's present on the corresponding hand motor cortex. And so that's what you're seeing here. In the upper left is the depolarization on primary sensory cortex, and the lower right is the hand primary motor cortex, and the isoelectric white strip down the middle of the diagonal of the electrode array is the functional central sulcus. And what you can see here is very similar to what Sergey was showing in the diagram. One of the diagrams that he showed is that the vein that corresponds to the anatomic sulcus is not the functional boundary line between motor and sensory. And so understanding that in real time in the operating room is really important for figuring out exactly where do we put these electrode arrays. So it gives you a sense of why having a movable, non-damaging electrode array could be quite helpful. And I'll show you one other kind of neat thing, which is Sergey mentioned that oftentimes the primary motor cortex proper is actually located intrasulcally, and that meaning it's not on the crest of a gyrus; it's in the valley between essentially in the valley of the central sulcus. And so placing intracortical electrodes in that valley can be kind of difficult for perhaps obvious reasons. And so we tend to place the intracortical electrodes on the crest of a gyrus rather than in the sulcus. And one of the things we can do with these electrodes is to place them in the sulcus. And so here I'll show you how we figure that out. It's an example of putting the tool in the hand of a surgeon and him sort of doing his own thing. So these were we use these electrodes in some cases in patients with brain tumors, because we've been using them adjacent to standard electrocorticography, and one of the ways we clinically localize motor cortex and somatosensory cortex and try to avoid hurting a patient when removing a brain tumor from an eloquent area is to electrically map those critical areas. And so what we've been doing as part of our clinical studies is to use the high resolution precision arrays alongside or as a temporary substitute for the standard of care. So this was a patient who has a breast metastasis just underlying her primary motor cortex. So it gave us an opportunity to show how to use high resolution functional mapping in a case like this. And so you'll see, so here the brain is exposed in the operating room in a conventional fashion. This is the craniotomy. The expanded gyrus there is where the tumor is. And I'll just pause this for 1 second. So here, this is how conventional mapping is done with the standard grids and strips, the same things that many of us have used in research, in an opportunistic way. But this is how they're used to map. In this case, I don't know if you can see my pointer, but electrode 6 in this case is over her sensory cortex. That that vein, and sulcus is the central sulcus, and electrode 7 is over her primary motor cortex. So the top left of the screen is motor, and the bottom right is moving towards sensory posterior. And so now you'll see this is what the traditional electrophysiology looks like. I still find it kind of hard to interpret even after many years. But it's one of the benefits of having actually higher resolution is the graphical representation, in my view, makes it much easier to understand the electrophysiology. So here, instead of looking at time traces, we can render, like I showed you in an earlier slide, we can render a kind of heat map of voltage that shows this is here now unstimulated spontaneous cortical surface activity on 2000 electrodes. So even this is kind of like a interesting technical hurdle to be able to render this in real time, and of course processing it through a CNN in real time is also important. I won't dwell on that since Sergey talked about that very elegantly already. So I'm trying to talk about some other aspects of the work. So here what you can see is the surgeon has opened up the central sulcus, running straight down the center of the screen here, and you have a 1,000 channel electrode array that's crossing over the curved crest of the post-central gyrus. So that's the sensory area down into the central sulcus, and on the other side you have a electrode array that is spanning the crest of the precentral gyrus, which is classically the motor areas, and you also have electrodes that are tucked into the sulcus. So you have the whole transition from sensory to motor with basically no gaps. And what that allows, I'll try to just show you that in the operating room here, we can actually see this is just by dichotomized voltage. So you're seeing red is positive and blue is negative. And what you can see even as the brain gets deformed during surgery, is you can see a clear transition from sensory to motor that happens inside the sulcus. And that has implications for when we're doing these surgical approaches to eloquent areas. And of course, it also has implications for the world of BCI and our ability to really span all of the relevant motor areas. Maybe I'll pause there just in the interest of time. There's so much more to show, including resolving individual finger function and the implications for decoding speech in awake patients, and of course real-time decoding of movement and gesture. What we're doing with our colleagues at Penn to show that we can decode intention to move and gesture down to the level of fine motor control for finger and hand type applications. But I wanted to try to just complement Sergey's talk by showing how we've begun to productize the whole system and find some ways to address these issues of real estate and functional localization, and to give you some insight into the role of microelectrocorticography as a tool for extracting decodable information for brain-computer interfaces, both from the neuroprosthetic perspective and I think also for other applications in clinical medicine. Thanks again for having me, and certainly happy to take questions. And there's so much more to say on all these topics that we'll save for another day.
Thank you so much. The talks were just so informative and fascinating. I posted the Discord link in the chat. If anyone is a BCI member and is not already joined, maybe we could throw some questions in there. But for those who have a couple minutes, feel free to, I guess, shout out some questions.
I'm happy to stay. I know I went a little longer than I planned to, so I want to respect the promise of Q&A.
So actually, I want to thank you, Borja, about these talks, because I think that give all really how the potential of what BCI can do for patients, and in future what it really can do. So it was really inspiring. So thank you. And actually, I would like to have your vision. So how you envision also the next step for the BCI technology, to have it as a medical device like pacemaker, for example, So, because I think that like the main challenge is also the accessibility and scalability, because when one do like clinical trials, you have like strict inclusion criteria and so on. So I would like also to see your point of view on that.
Yeah, thank you for the question. So I tried to orient the talk around kind of answering or maybe provoking just that question,
exactly.
because we of course are building a product, and at the same time, and that product when it comes to regulatory approvals and indications and labeling and clinical trials has to have very strict criteria for for outcome metrics and safety and so on and so forth. This is also, in the transition from academia into the world of, standards of care, there is this internal tension that we wrestle with. And I think this has been true for, my entire career to date, which is how much programmability do we allow? How much do we say we're going to like bake in the algorithms? How much change control can we legitimately put in? How much of a different world is this today from, say, the sorts of algorithms that control pacemakers or deep brain stimulators and so on? I mean, we know that it's a different world, right? The kinds of decoding algorithms that go into BCI are fundamentally different from the control algorithms for current steering and even a cochlear implant. So at the same time, we want to have tools that we put out into the world that are useful beyond just a very, very narrow indication, and we want to have a product that has the potential for expanded uses beyond, say, just ALS or tetraplegic patients with a high cervical cord injury. I think many of us believe that cortical controlled BCI have many potential applications, and I certainly believe actually that these sorts of the high channel count, high resolution electrophysiology is going to have an impact in clinical medicine way beyond even just BCI and neuroprosthetics. So one of the ways that we do that as we move towards clinical trial work is close collaboration with the sponsoring investigators or the collaborating investigators, and we've already begun to do that. I didn't really highlight it too much in what I showed, but each of the centers that we're collaborating with has its own special interest. So Ian Higas is the neurosurgeon at Penn who we're working with very closely, and he has a special interest in motor control. He's a functional neurosurgeon, with an interest in motor control, and so our collaboration is around understanding what happens on primary motor cortex, synchronized with what's going on in the subthalamic nucleus and the deep structures that are stimulated in DBS. And so the clinical trial data that we're generating is useful, scientifically to him and to us. And similarly, when we've brought these electrodes into the operating room around, for surgeons operating around eloquent brain areas, they're looking at how to understand where speech is located and where receptive language is located and where hand motor function is located in order to keep the patient safe, and make a fine distinction between what's brain that can be removed or cut and what's brain that can't, and where the tumor is and so on. And we're interested in the motor areas or the speech areas for their own sake. And so I think we're trying to make these tools available as part of the clinical research, and we're also committed, even in this, as I mentioned, this first stage product that's going to be hopefully approved in the next couple of months. That will be a FDA cleared, knock on wood, FDA cleared clinical tool, and also a tool for clinical research and clinical science. So we really hope that this technology will open doors beyond what I don't think is such a narrow indication of BCI, but even beyond.
Thanks a lot.
Great. We've got a question from Franklin for both speakers, centered around stimulation. He writes, we've seen such exciting work with decoding, as both of you mentioned, but he's curious about what sort of disabilities could be targeted for stimulation in the context of BCI, and what should be the first steps for addressing clinical stimulation.
I
Yeah,
see
I
Sergey
think-
smiling. Why don't you go ahead?
Yeah, I can just go first. Yeah. Definitely stimulation is going to be really important for a lot of applications. So actually, like my own research journey, I started my postdoc working on brain-controlled robot arms, actually really inspired by the work coming out of Pittsburgh and other places. I see John Downey in the audience, so he knows obviously a lot about this. And one of the things that I found very hard is unless you can restore a sense of touch and proprioception, which people like the Pitt and Chicago groups are doing, we had great like endpoint decoding. We can kind of do VR tasks with high accuracy. But you can't really like handle objects well. You can't pick anything up. So that I think is a very clear indication where we need, not just stim, but like high bandwidth, precise stim, spatial temporal patterns. It's hard to write in naturalistic sensation. So the readout problem is hard, but easier than the write-in problem. And so my own like decision to work on speech really stemmed from feeling like, although I think the neuroscience of speech and the decoding, the ML is harder because you don't need to do write-in to make a therapeutic system. I actually predict that this would be like a commercialized system first, and time will tell. But yeah, so any sort of object handling on the BCI space obviously needs write-in. Also, restoring vision, which a lot of people are also working on, clear indication. So yeah.
Yeah, I agree with all of that, and I think there's a long history also of interest in stimulation as therapy, as we've seen in conventional world of neuromodulation, and so I think a lot of things will be tried, and we'll see what happens. There was a period of time in which there was a lot of enthusiasm around cortical stimulation for motor rehabilitation from stroke, and I think that that will be a very interesting area. I think it's going to be interesting when we have the ability to both look at motor-related areas as they recover, or to figure out what is potentially recoverable penumbra, or incompletely damaged cortex, and understanding what's electrically viable and what is not, and what is potentially plastic and responsive to stimulation. And I think that earlier tools with which this was tried, for example, the much analyzed North Star experience, maybe that there's been a lot of speculation, but I think bringing a new generation of finer grained tools for stim and record, I think we'll give another shot at what it means to do therapeutic stimulation for stroke rehabilitation. So I think the jury's out on that. We need carefully designed work, but it's such a big problem, and the decoding side of BCI, record and decode side of BCI, is going to have so much impact in stroke that it's, I think, going to be very tempting to see whether adding stimulation to that arsenal, can do even more than BCI alone. And of course, everybody is always asking about depression, just because the potential impact of that is so big. I think for me, depression has, and other psychiatric disorders has always been like a very difficult nut to crack, because I think we have a much better understanding of the circuitry and physiology involved in movement and sensation, and speech as a subset of movement, and even vision. When it comes to more complex things, it's for me, it's hard to really totally crack that nut, but that's an area where people have thought a lot about stimulation, and I think the DBS world has been focused on that with a new wave of activity, and so people are asking the question of what role does closer to the surface work have in in psychiatric disease. So I think anything that involves clinical neuroscience, people are going to ask, can you apply neurostimulation here to affect it? So but I think I agree with what Sergey said, and I would just add stroke rehabilitation as a really interesting and promising area also.
Yes, certainly. I've got a quick question, Dr. Rapoport. You mentioned your microslit technique. What kinds of imaging do you think about, or kind of pre-procedure imaging do you do when you try to plan out, where exactly to go in with the microslit? And you mentioned these electrodes go under the dura. You look at, vasculature in the area and stuff.
Yeah, the imaging workflow is very similar to what's current. If you're familiar with the ROSA type workflow for stereo EEG, it's very similar. It's very similar, except that instead of going to a depth, you're going along the cortical surface. But the need to have high resolution stereotactic quality imaging to do trajectory planning is the same. And yes, we do trajectory planning as well as looking at surface vasculature. And then there's the question of what is the right functional area to be targeting. And there's a number of ways that we try to guess that ahead of time, through fMRI and tractography and so on. And then the one thing that I would say is sort of different between working tangential to the cortical surface and working perpendicular to the cortical surface, like in DBS and SEEG, is that this is not really a percutaneous procedure in the same way that that stereo electrode placement is, because you in order to safely insert the electrodes and make sure that you're in the plane of the of the subdural space and not intracortical, we have to treat the tissues and tissue planes as deformable, which they are. So it's sort of microsurgery, not just percutaneous type procedure. We do have to make sure that the bone incision goes down to the dura. So that requires both, a good quality, CT or MRI, and also some, an endoscopic look at the work that we're doing as we drill. And then a separate dural incision needs to be made. And so it's not just radiography, but also, a tiny little endoscope that we use to look down the borehole and make a safe dural incision and make sure that we're inserting the electrodes, under the dura and above the peel surface.
Mm-hmm.
So it's a combination of radiographic, stereotactic type planning and microsurgery.
Mm-hmm.
We have another question.
Hey, Dr. Rapoport, thanks very much for that talk. That was really great. Since we have your talk with microECOG here and a previous talk with intracortical, I'm just curious, given your experience in the space now, you talked about some of the advantages of your approach and some of the trade-offs here, but in terms of kind of application spaces, do you have a sense of this technology is right for this application space that maybe intracortical would, and vice versa? Are there application spaces that you wouldn't want to go into with microECOG? Or is it
I think we'll see. I mean, I think for BCI, I personally think microECOG is just a great modality. I mean, but there's no electrode technology that's one size fits all, right? And so I think we'll see over time, what's right for what niches, and there will be some things that I think will probably be functionally more or less equivalent. So I think time will tell, but I think that and I think not that much more time will be required to tell. I think we're going to be discovering that over the next couple of years as a number of these systems move into human clinical trials.
All right. Well, maybe we'll stop it here. Sorry again, everyone, for the mishap. We'll make sure to remedy that next time. We appreciate Dr. Stavisky and Dr. Rapoport for your time. Really engaging talks. For those who joined late, this is recorded. We'll find a way to post the entire talk. So we appreciate everyone's attention and their time.